So I'm Dr. Charles Denton Johnson. I'm the director of the Public History Program at North Carolina Central University. And this is a roundtable on the state of Black health and future medical trends for the ASALH Health and Wellness Conference, our 107th annual meeting and conference. This moderated discussion will focus on major African American health issues, preventative care, treatments, and future health and wellness trends. Currently, 48% of African Americans are obese, and more than half of African American women are obese. Participants in the roundtable will address health-related issues impacting African Americans and provide solutions. Without question, African American history and African American health and wellness are correlated. Diseases that are common to African Americans, such as high blood pressure, heart disease, kidney disease, and diabetes, are rooted in the historical experiences of Africans during the European-dominated trade in African peoples and enslavement in the Americas. Many enslaved laborers had diets high in carbohydrates, low in protein, and low in calories, which weakened their constitution and made them susceptible to disease. Today, historical and systemic economic hardships, which are a legacy of enslavement, continue to cause diet-related health disparities for African Americans relative to whites. I have the great privilege this evening to be joined by 5 African American physicians who I will introduce, but I want to express my gratitude to them for joining us. In alphabetical order, we have Dr. Cedric Bright, who is at East Carolina University, is the interim vice dean, associate dean for admissions, professor of medicine at the Brody School of Medicine at East Carolina University, and a past president of the National Medical Association, the NMA. We have Dr. Tamara Coyne Beasley, MD and MPH, who is professor of pediatrics and internal medicine, and is the Darrell M. Dawkins, MD, endowed chair in adolescent medicine and vice chair of pediatrics for community engagement at the University of Alabama at Birmingham. She is a past president of the Society for Adolescent Health and Medicine. We also have Dr. Brian Curry, who is the director of the Division of Cardiology at HCA Florida Ventura Hospital and Medical Center in Aventura, Florida. Dr. Jensen Hall is an assistant professor in the Department of Internal Medicine and Division of Nephrology at Duke University and the Duke Molecular Physiology Institute, faculty at the Duke Molecular Physiology Institute, and vice chief of diversity, equity, and inclusion for nephrology. He is also project co-lead of NRMN/CIMER. Dr. Maria Jacqueline Small, MD and MPH, is associate professor of obstetrics and gynecology and maternal fetal medicine at Duke University Medical Center. Let me say thank you again so much to each and every one of you all for being here. We are coming together at a time in our history where African Americans are facing so many different challenges coming out of COVID. And now I believe we have monkeypox that seems to be menacing our communities and so forth. So there's a great deal for us to touch on, including healthcare issues of long duration that we are still dealing with. I want to start with a question that will allow our audience to get to know you just a little bit. And I'd like to start by asking, I'm just going to ask you all, you can unmute as you would like in this instance, to tell us why you decided to become a physician.
All right, I'll jump right in then. I actually didn't have anyone in my family who was a physician, so there wasn't kind of that role modeling that would have propelled me to do that. But what actually did propel me still was my family, because my family had lots of illnesses and actually was fraught with premature death as a result of that. And so my interest in science, and also my interest in math as well, and just seeing all the what I viewed even then before I was a physician as unnecessary deaths among my family really kind of was the impetus for me to actually go into medicine.
So I'll go in and jump in second. I read a book when I was about 3 or 4 years old. My grandmother and father used to tell me they bought these series of books. This is what a nurse does. This is what a doctor does. This is what an engineer does. My brother and I read the books, and one day we were playing in the yard and came around the corner. My grandmother heard us say, my brother said, "Well, Cedric, I think I want to grow up to be an engineer." And I said to him, "Well, that's cool, Andre. I think I want to grow up to be a doctor." And fast forward 25 years later, I was a doctor and he was an engineer. I think I solidified my wanting to go into medicine when I was probably about 12 or 13 years old, and I got an infection in my leg. And when I went to the doctor said, well, they told my mama, well, Bessie, I'm glad you brought him in when you did, because if you'd waited a couple more days, we would have had to amputate his leg. Fortunately, she was able, Dr. Elizabeth Conrad, I'll never forget her, was able to give me antibiotics, and it saved my leg. And I said, man, if that is the power of a doctor, I want to do that.
Well, I don't have as remarkable a story to tell, but I think I came to medicine, or an interest in medicine, through the television. There was a TV series called Quincy, and although he was a medical investigator, I just really liked the way that he dissected cases and came to conclusions, all kind of in a convenient 1 hour time frame. But it sparked my interest in medicine. And alongside that, there were several opportunities in Baltimore, where I'm from, with the public university, University of Maryland, where I ended up doing my MD PhD. Plenty of opportunities to do research as a person in high school. So those two interests kind of converged around that period of my high school training. I wanted to be around physicians so that I could kind of get a better sense for what they did. I also wanted to be around researchers because I knew that one way or the other, I was going to be doing research. So that's how it came together. And once I found out that there was an opportunity to learn how to do both in one career, that's the route I took. And it's the smartest decision I ever made.
You're muted.
You're going to have to unmute Dr. Small, thanks.
Apologies. I came to medicine a little bit circuitously, unlike some of my colleagues. I'm originally from Durham, North Carolina, as many of you all have talked about, which many people know of as the city of medicine. But I spent most of my summers in eastern North Carolina, which is a more rural area of the state and where my parents are from. And I worked on my family farm every summer in tobacco and doing a lot of kind of backbreaking work over the summer. And I remember people would say, sometimes jokingly, sometimes not so jokingly, you all better be careful because the doctor's on vacation. So it was the doctor. And sometimes the translation was the color folks doctor. And sometimes it was just the concept of not having enough medical attention in that area of the state. I also, that stuck with me. And then also, as I got into, I think, my first high school opportunity in a pathway program took me off the farm for a summer, which I was very happy to do, and exposed me to science. And it was a way to really start to be introduced to potentially a science-based career. And I joined those two together and was interested in both serving in areas that were underserved, like my own area of North Carolina, particularly Eastern North Carolina, and also just being able to give something that is very important to the health and well-being of people who did not have access to care. So that's what took me to medicine.
Dr. Small, what part of Eastern North Carolina?
I was in Clinton, North Carolina, which is Sampson County, and that is, as we have on the panel, Dr. Bright is in that area serving at the university there.
Mhm.
And many of us have those roots. And then my father's from Wilmington, which is the coast.
Well, I developed an interest in medicine at a somewhat young age. My father is a cardiologist. My mother was a nurse, and I was exposed to it. There was a lot of discussion, usually around the dinner table, about scientific careers and lots of discussion about what goes on in the hospital. I did not like seeing a lot of relatives who were sick with chronic illnesses or dying prematurely. And I had a curiosity about why that happened and what could we do about it. And that, combined with my love of science and math, led me on a medical career.
Excellent. All right, I'm gonna go ahead and move into the next series of questions. And what I would like you all to do, I'm not going to pinpoint anyone necessarily unless it speaks to your medical specialty. And we have a great diversity of medical specialties on this evening. But I would appreciate it if more than one of you would give comment to those questions that you have an interest in responding to. So what is the state of African-American health in the United States? And what are your most pressing concerns about that?
So if you don't mind, I'll lead this one off, and I'm sure my colleagues will jump in. Looking at the state of African-American health, we would say that while in many areas we have improved, there's still many areas that we need to improve. Access is still a key issue, as Dr. Small has already mentioned, in our rural areas and even in our urban areas. More importantly, what COVID has shown us in the last years is still we're very vulnerable. As it is always stated that when America gets a cold, Black people get pneumonia. And that was absolutely true as it relates to COVID-19, where we saw that African Americans were dying at an 8 times greater rate than our white counterparts. A lot of this had to do with some of the structural impediments of health, as I like to call them. When we talked about people need to shelter at home, many people were working essential jobs that did not allow them to shelter at home. Not only if they were able to shelter at home, all of them, they were living in intergenerational housing, which made them exposed to even more because of children who were trying to go to school initially, who then later were not, and then could often bring the virus home and then spread it to all 3 generations within a household. So we can look at the issues of heart disease and diabetes and kidney disease. And while we have made improvements, the gap between outcomes in white populations and Black populations has not closed. In fact, some of those, it's actually increased. So while we have some areas that we have improved, overall, we still haven't closed the gap. And the last thing I would tell you is that with COVID, we actually lost 3 years of lifespan compared to white populations with COVID. So that's a very important aspect because we had recently gained on that. But with the COVID, we actually lost 3 years of lifespan.
So Dr. Bright, what does it mean that we've lost 3 years of lifespan? Can you help us to understand that?
So when we talk about the excess deaths that occurred in the Black population, there were so many excess deaths of young people that it lowered the average age of death of Blacks by 3 years.
Is there anyone else who'd like to respond? Unmute Dr. Coyne Beasley.
Oh, sorry.
So I actually just want to echo what Cedric said, and just to amplify that by saying, not only does it impact the current individual who is experiencing racism, but we're, as a pediatrician and as an adolescent medicine subspecialist, want people to understand that it just doesn't affect the individual. It actually affects the unborn. It actually affects the children who will be born from that female, let's say, because the stress that's caused not only by the racism that people experience actually creates what we call epigenetic changes, which actually occur in the DNA that make it fragile and vulnerable in many different ways, such that the stress and the illnesses that can come from these changes related to stress and racism actually can impact subsequent generations. And so I think it's really important for us to understand that when we're looking at an individual and she or he are put in a situation in the United States that is very much biased in many ways, those changes don't just impact the individual, but also the children. And just also to amplify what Cedric said, there's almost every single measure that you look at, every health outcome, there will be a gap between whites and people of color if that disease presents itself in people of color. And so when I think about kind of what are some of the etiologies of these, and Cedric, actually, Dr. Bright went through some of those, it's not just racism, but it is the racism that leads to the social determinants of health. So you heard him talk about living conditions and work conditions. And you, in your introduction, even talked about the food that people have access to. We're in a system where we have, I heard him use another word instead of structural racism, but it's a structural racism that causes these disparities and impacts not only the health of individuals who are living, but subsequent generations.
I feel like that was just a softball to me as the OBGYN in the room. Dr. Coyne Beasley mentioned epigenetic changes, things that can happen in the womb that are that can affect the expression of genetic or disease. So, for example, an individual that may have a baby that's born very small, low birth weight, has that particular baby may be at higher risk for cardiovascular disease and at higher risk actually for obesity because of in utero or in the womb stress that then goes on to manifest genes that may increase the risk to that particular child. So in OB, in obstetrics, we are frequently addressing now, and it's become much more prevalent that people are aware of the higher rates, 3 to 4-fold higher rates of maternal death for Black women, for brown women compared to white women in the United States. And some of those, the reasons for those inequities are related to structural racism as we analyze and go deeper. And things like COVID, we saw that for Black women in the United States, this disease, because of those social drivers and social determinants of health, like where you live, where you work, access to care, made our risk in pregnancy for death about 15 times higher than for white women in some cases. So pregnant individuals in general are at higher risk for death due to COVID. But then for us, the risks were much higher than our population numbers in many states that showed outcomes by race and ethnicity. And the other thing that we know, and this is something related to maybe cardiovascular health and kidney health, we know that areas where you have more even green environments where people can walk and do things that are more maybe calming, that those areas people may have better cardiovascular response or better responses to stress or things related to stress that make your blood pressure worse. So even things like having areas where there's no access to parks or green or trees may have an impact on our health. And many of those kinds of settings are also determined by structural racism in this country. I'll pass.
I actually, all the points made previously are perfect setup for something that I'll mention that's really not biologically related, but it has a major influence, and it's the influence of civic society. One thing that this past 4 or 5 years has highlighted for me in stark relief is the importance of being engaged civically, more than just being focused on, this, that, or that election, but really thinking about how government facilitates all of the aspects of life that were just mentioned. How do you get your care? Who handles, who are the people that handle emergency situations in your area, your district, your street, your zip code? How do those functions of government get deployed when there's an urgent need? And what mechanisms do you as an individual have that you can use to help strengthen or support the proper functioning of government in your local area? So much of that collapsed in during the pandemic. And since we're not out of the pandemic, I would just say that it collapsed during the height of the pandemic, especially in the African American community. And I think it's just so important to connect our civic responsibility, civic engagement to health. They're not separate; they are all together. And so, when you're making decisions about how to engage the world politically, it needs to be a multi-dimensional consideration. Um, how I am leaning in one direction might very well influence my neighbor's access to care or my neighbor's health and well-being. And because we are all inextricably linked, as Dr. King said, in a single garment of destiny, anything that you do that compromises your neighbor's ability to receive care and treatment when it's needed ultimately compromises your own. And so I think there's definitely a need for a re-engagement with the idea of community and all of us being joined together so that we can make decisions for the group that may not necessarily seem like they benefit you individually in that moment, but certainly could provide a net of safety for you in the future should things turn in a way you don't predict. So it's just this was a really interesting crash course in how prepared is the African American community for a major shock, and I would have to assess our readiness as probably a D plus, and that's really concerning because much of that does not have anything to do with our particular influence, but certainly as it relates to civic engagement, there's quite a bit more that I think we could do. We just have to know what the levers are and be willing to pull them.
Well, I can't just leave that kind of like that. Speak more about what, from a pragmatic sense, what can we do, right? What are some of the solutions that you've touched on in terms of being involved in civics and so forth. But what else can we do that would better prepare African Americans and give us a better chance, I guess, in terms of our health and health delivery as it's needed in our community? So what are some of the things that we could do?
So I would just say that the re-engaging with history, really taking the time to understand the price that was paid for some of the gains that we made through the 20th century civil rights struggles and so on. Why was Dr. King so obsessed about securing the right to vote for African Americans? He wasn't the first one. You all are from North Carolina. There was a congressman in the post-Reconstruction era by the name of George White. He has a town named after him. And he was one of the last congressmen that was able to participate in governance post-Reconstruction. many had been ejected, particularly in Wilmington was where he did his representation. Many had been ejected. And the point is that the vote, he saw it, and then decades later, Dr. King saw it as a major lever in this system of government that we have to articulate your voice and move your situation more towards the benefit than to the harm. But it was something that was continually denied, because if you can't, in order for the system to be legitimate, the vote has to stand. Mm-hmm. So the best way to get people not to participate in the franchise is not to murder them in the street. The best way to do it is to get them to participate in their own disenfranchisement, which meant cancel out the vote. And so there are all sorts of ways that you can see that happen, all sorts of political maneuvers. But it stands out to me, particularly in Dr. King's example, who faced death in so many different ways and lived a life of continual threat, with one of the major goals for him being securing the vote. And when you look at voting participation in midterms, just sort of local elections, the presidential election, the lack of enthusiasm in some quarters, I think, really does betray all of the struggle and the hard-fought wins that happened in the 20th century by so many people who even come from this area of the country.
So Dr. Hall, let me jump in here right quick. Yeah. You talked about what happened in Wilmington, but you didn't talk about the massacre in Wilmington when all of the blacks were elected into positions.
That's exactly what I meant.
Just massacred them all, right?
That's what I meant by thrown out.
Instances, yep. Right? No, that's not thrown out. That's called massacre. That's an insurrection, just like January the 6th was, right?
That's right.
We talked about the political gains that we had, and you didn't talk about the fact that it was the black vote that got Biden into office this year.
Absolutely right.
We didn't talk about how Warnock was voted by the black people in Georgia. So we have exercised many of our civil rights, but what we have to do is make sure we have to do it on a consistency.
Basis. That's right.
Right.
And so
the number one thing that I see is we have to dismantle racism. Every aspect of how racism impacts our communities, we have to learn how to dismantle it. We talk about, from the public health perspective, there are things that are upstream and then there are things that are downstream. We as medical professionals meet all of our patients at the downstream component of health, right? What we don't know about is all the upstream effects of, like, how the healthy communities, healthy jobs lead to healthy people, right? But if you don't have a healthy community because you've been redlined, and you don't have healthy schools because the tax base of your neighborhood determines how much school resources that you have, then that leads to people, the community that are not healthy, that leads to unhealthy people, which then leads to unhealthy behaviors or leads to unhealthy exposures. We don't talk about exposures, how oftentimes we're relegated to the side of the railroad tracks where we're exposed to chemicals and things of that nature, which then impact us down the way and affect our birth rates, affect our maternal mortality rates, and all of those things. All of those are structural policies that are all because of what racism started from with slavery in this country. And the beginning of slavery has been an impact on all of those aspects up until today. We talked about epigenetics. That's a reflection of generational trauma. Absolutely. Because of racism. I'll stop there.
Can I chime in real quick? Because I have to get on the Wilmington part, and I have to go back to what Dr. Hall started out with. And the reason we're here is know your history. And I think one thing that is so important about what you said about know your history is that history that happened in Wilmington post-Reconstruction, when there was a multi-ethnic government, that history was not known to us until recently. So, that kind of, there's a reason why that history wasn't revealed until recently. And some of that is part of the structural racism, and also keeping us mentally from being able to actualize real change and know that, like you said, the vote means change, but you have to understand what you're voting for and what the impact will be of that vote. And Dr. Hall and I sat on a committee together to address structural racism in our institution. Sometimes when you're living in these institutions, the institution, we keep saying, is not doing anything other than what it was designed to do or designed to be when health inequities are perpetuated. And so for us as people who've been taught by some of the folks that perpetuate these inequities, a lot of the process of breaking down these structures also has to do with us stepping outside of some of these, being able to see some of these systems and structures in healthcare and in our institutions that are that we need to reimagine.
Right.
And COVID, with all of the horrors of COVID, really showed us where the cracks in the system were and where people were in multiple institutions really had no access, no entry, even in institutions that claim to want to serve the community. And I'll pass.
And I just in follow up to Dr. Bright, and
Well, Dr. Hall, can I ask Dr. Curry to if he'd like to
Well,
get some input on?
I was thinking about how to add on to all of that. It's interesting. I did not know about Wilmington until recently. I didn't know about Tulsa until I went to college. And there's a lot of history that we are not taught and don't hand down. It's sort of erased, and it's all important. But I was thinking about how COVID did show all of the cracks. I work in the Miami area, and there's a geriatric population here, and most of the patients rely on transportation from various clinics to get to their doctor. But during COVID, they're being told, the distance, those are cut off. We'll do televisits, and you don't have internet. You can't get to the doctor. And looking at the piece of taking care of patients, most of the Black patients don't have doctors that look anything like this panel.
I think Dr. Curry's screen has frozen on us there. I want to keep moving. There's some other questions that I want us to have an opportunity to touch on. And Dr. Small, I'm going to come back to you because I'd like us you started in on it, I guess, a little earlier, but what are the issues, or what issues are most impacting the health and wellness of African-American women?
Well, I think they're the same issues that impact us in general because we are not isolated or in a vacuum. There's certainly some issues that have been, like we mentioned, brought to the forefront in terms of maternal health. And maternal mortality, fortunately, is one, not fortunately, but I am glad that issue has become one that is very prevalent as a talking point, as something that people understand and are willing to work on. Infant mortality and infant mortality inequities are still very prevalent and have been prevalent for as long as those numbers have been collected in the United States. So I think getting back to how do these things all fit together, the baseline health and baseline wellness is so important for how you enter conditions like pregnancy, how you live postpartum. And we're finding that some of the biggest driver or biggest cause of maternal death now is cardiac disease. And cardiovascular disease is one that so many social determinants and social drivers of health impact. The presence of high blood pressure prior to pregnancy, kidney disease prior to pregnancy, both that may not be well controlled, being able to take care of and know blood pressures after delivery, and being in a setting where you can get access to the care of a cardiologist, a good internist. All of these factors are so important for the health in a circle of continuum for women, but even important because what happens sometimes during pregnancy gives you an idea of what individuals at high risk for later in life. Like if there's preeclampsia, which is high blood pressure in pregnancy that usually goes away after pregnancy, that lets us know that someone's at higher risk for cardiovascular disease. And she needs to be able to be in touch with an internist, a cardiologist who are aware of that history and are going to try to help her manage the things that may put her at higher risk for those outcomes, to be able to decrease those risks, to modify those risks. So with that, I'll pass.
Let me just follow up real quick. When I opened that, I talked about, I quoted statistics about obesity and so forth in our community. As it relates to women, what are the implications of our diet? And what's wonderful about this is you all are making the social connections, right? The implications of where we are as a people out of the history that we have come through, and how that impacts our health and so forth. But I'm at an institution where I can say, many of our young people, I'm at North Carolina Central University, the best institution in the country. And many of our young people come from down east, like I was speaking of, doctors. And if you look at their diets, they're high in fat and low in the kind of nutrition that we would like them to have. What are the implications of that?
Can I start, please?
Yes.
The first thing I would like for us as medical providers to make sure we avoid when we discuss the issues of individuals who may have obesity is not shaming and blaming. And I think that is something that disconnects us from individuals struggling with weight, and also may take a little bit away from the issues that are prevalent. So first is, we know that in some communities, and this is part of the social drivers of health, people don't have access to fresh fruit, vegetables, the kinds of foods that we say are healthy. And then the other thing that I want us to really think about is how certain foods are pushed on our people, similar to the way drugs may be pushed on individuals who may even have a drug addiction problem. So the kinds of food that it's considered very acceptable to see advertisements for very unhealthy, supersized, poor quality, high fructose containing compounds, even though we know that obesity is one of the leading drivers of cardiovascular disease in this country. And yet there's no regulation on how food can be packaged, distributed, and pushed and advertised. That's one point. And then the other part of that is, it is a huge, huge, huge issue. And it affects, for the reproductive side, it's more than even cardiovascular disease. It affects the risk for infertility, affects pregnancy, the risk for death in pregnancy, and for severe outcomes like high blood pressure in pregnancy, diabetes in pregnancy, and then even later, things like the risk for certain cancers. So knowing this, I feel that we as a society really need to think about how we talk about this condition, how we try to engage people in not only the self work, but also how hard it may be to really make those changes, because you're swimming in an environment where everything is working against you.
The groundwater, in other words.
There you go.
Dr. Coyne Beasley, can you unmute?
Yes, thank you. So I thanks my colleagues for kind of a really wonderful articulation of obesity. And again, just thinking about shaming and blaming, I think it's really important that we don't do that. And in addition to not having access to quality food, we also don't always have access to or finances to go to the expensive gym or even to walk around the park. But I also want people to understand that obesity is actually probably the most common chronic illness that we have in this United States, and not just among people of color, but it has more drastic conditions for us. So when we think about obesity, it increases your risk for cardiovascular disease, whether you're pregnant or not. It also increases your risk of cancers. It also increases your risk of diabetes. And I also want to make sure that people understand when we talk about the epigenetic changes that can happen when people have stress, and stress particularly from racism and other isms that come from the discrimination that people experience. Obesity is one of the most common outcomes that happen not only for that individual, but also transmitted down to their young people. So when we look at our situation and just kind of capitalizing again on what Dr. Small has said, many people have been programmed because of the conditions in which their families lived in that make them predisposed to obesity. When I think about obesity from the children's perspective, and that's probably one of the things that's most alarming, is that we're starting to see obesity in almost half of our children, particularly children of color. And not only does it lead to some of the health conditions we've already talked about, it also creates situations where violence can actually occur, when there's low self-esteem, and a whole other host of issues related to violence that can also be very detrimental to our young people as they grow and develop.
So, Dr. Johnson, that brings us to the point of understanding what is health and how do we define health, right? And so, in my perspective, from what I've seen, there are two definitions of health. One is the health of people that have means and have insurance, and then there's the health of people that don't have insurance. The health of people that have insurance is I go to the doctor to maintain my health, right? And those who don't have insurance say, I go to the doctor when I am no longer able to perform the activities that say I'm healthy, right? And that makes a big difference because it changes the paradigm on how do we get well. You know, it's easier to stay well as opposed to get better, right? And so it's very important that we understand that. And then when we think about those that are of that ilk who don't have health insurance, they're the biggest payer of healthcare, right? They're the ones that have to take a day off from work and they work an hourly job. They have to find transportation to get to the doctor. They have to pay the copay when they walk into the doctor. They have to pay the facility fee once they get the bill from the doctor. And if they get a prescription from the doctor, then they have to pay for that. And did I mention child care? Just in case they had child care to get there, you know? And so in the end, they don't have an insurance company that negotiates what price they pay. They get the full price. And that's why healthcare is the number one cause of bankruptcy in America.
So there's one thing I'd like to actually add to that. And thank you, Dr. Bright, for that. So that's one dimension, and it's actually a really important dimension. But there's another dimension that actually accounts for the reason why, irregardless of what your SES is and your access to healthcare, you have, as a Black woman, still a higher risk of maternal mortality. In fact, we have a scholarship at our institution for a Black physician, female physician, who died in childbirth. So when you think about kind of access to healthcare, it's really important to not only be concerned about getting there, but what happens when you get there. So what are the systemic issues within healthcare that bias the kind of care you get, irregardless of what your SES is? And that's clearly, I'm sure one of my colleagues may want to take that and develop it further and give them that opportunity. But there are lots of things even within the system of healthcare, once you access it, that may put us at risk, still at higher risk of not getting appropriate care, not getting timely care. And that has to really do with some of the biases and structural racism that are built into healthcare. And so I can talk about those as well. But the point I want to make, and allow my colleagues to do the other piece if they choose, is that we need more healthcare providers that look like us. And part of that also means making sure that just like every single one of us who saw something or experienced something that made us want to go into medicine, that we make sure that younger people who are Black and brown have the experiences of understanding that they too can go into medicine and what that looks like and why that would be important.
Excellent. I appreciate you beginning to speak to solutions in terms of getting young people involved in healthcare. I think that's really, really important. I'd like to ask a question about. I'd like to come back to you, Dr. Coyne Beasley. You know, we've kind of touched on some things with young people. But since I work with them every day, you know, the level of stress that they deal with, I'm so glad that I am not a young person during this period. It's incredible, right? The way technology has changed things. And, you know, we were probably all picked on when we were little, but you didn't have, social media now where it could be multiplied, to the nth degree. But can you talk about some of the challenges that our young people are facing as you see it? Unmute, please.
Sorry. Okay. All right. Maybe I'll just leave it unmuted. But you actually hit it right on the head. So when we think about now the leading cause of death for young people, it used to be motor vehicle crashes, but it is no longer. Okay. It is firearm deaths, either in the form of homicides and suicides. And so there are a lot of things about that. We can talk about the violence, but I'll talk about suicide first, since you actually kind of led us down that pathway. The amount of stress that young people experience is tremendous, and it's so much more than we have seen. And a lot of people attribute that to social media, and that is true. But there's also the regular media that causes a lot of anxiety when people turn on the TV. Most of us grew up in a world where news came on 3 times a day, morning, noon, and night, and there were 3 channels that actually gave that news, and it was at most an hour. Now it's continuously, 24 hours a day on 100 channels, a lot of channels, and it's not always accurate. And you've got to remember, not only when we were dealing with COVID, we were also dealing with periods of significant social and political unrest. Dr. Bright has already talked about January 6th, but we also had the murders of George Floyd, which people watched over and over and over again. And if you're a young Black male like my son, or even my daughter, and she thinks about the case where an EMT worker was shot, Breonna Taylor, it really, as a person of color, a young person of color, can create a system or a situation where you can feel hopeless. The other thing that COVID did for young people is that it actually caused lots of young people to not be able to go to school virtually. And if you don't have access, not to go to school in person, and if you don't have internet or the opportunity to actually do this in person and have the internet access, you're losing gains in school. And I want to connect back to something that Dr. Bright said. African Americans are more likely to go to less resourced schools, which are resourced by the taxes of the housing units in the community. So most of us, because of redlining and other things, are put in communities where there's low resource schools. You talked about something else, and I'm going to certainly allow my colleagues to speak, is developmentally, adolescents are going to make mistakes. They're going to do things that may not be unwise. That's how they grow and develop and transition into adults. The different, and they experiment. That's part of growing, and it has been the normal part of growing for history and will remain that way. But the difference now is that those mistakes that you made and people would forget about it, or maybe your close friends might laugh about it, now can be captured on video and shared in perpetuity with people that you don't know. So the ability to kind of grow and develop as other people did it's kind of been taken and snapped away from them. And this constant competition of being liked, on social media with people who, whether they friend you or not, are really not your friends. And so it really has created, we've seen certainly a surge in COVID, but we've seen over time that young people are becoming more depressed, more anxious. We're also seeing it manifested in eating disorders and suicide, which was not something that we thought of, that wasn't as high in our communities of Black and Brown communities as it currently is.
Is there anyone else who'd like to comment?
It is really tough being a young person. It really is these days.
I concur with that, and having a child that is on the spectrum is even harder at helping us to understand that, when we have special needs children, how do we help them deal with the realities of who is a friend and who is not? And how do we as parents help them to navigate those pitfalls that may come of them? And I think one of the biggest issues these children need nowadays is a reaffirmation that we love them and that we care for them, and that no matter what mistakes they made, it's okay to make a mistake. The mistake is not to get up from that mistake, learn from it, and move forward. I think that's very important, that we don't shame our children when they make mistakes, but rather give them the encouragement to be confident that they will make mistakes, but can grow from them. That's
right. Excellent. Look up, get up, and don't give up, right?
Amen. It's something your father probably taught you.
Actually, that's Michael Irvin, who played wide receiver for the Dallas Cowboys.
Now, why are you going to bring Dallas into this?
I'm going to talk a little bit about the National Medical Association and the important role that it plays in addressing issues of health disparities, right? And preparing the next generation. You all have already begun to talk about the need for that. The next generation of healthcare providers. Let's talk about the NMA some. What does it mean to African Americans and to African American healthcare providers like yourselves? Dr. Floyd, yeah, I was going to say we're gonna.
Well, actually, I'd like to have Dr. Curry answer this one because he's got a historical perspective about this.
Okay.
Well, it's interesting. The NMA, it's important, and I think a lot of people in the mainstream forget why the NMA exists. It used to be that you had to go through your AMA to get the CME to maintain your license, and if Blacks could not join, you could not maintain your license to get those continuing education credits. But the NMA has been very important. Often it's like a class reunion when we do go to the NMA. You get a sort of an infusion. You're around people that look like you who are doing the same things and are fighting the same battles. And there are people who are interested in people who look like you and your family. They're doing research in African American healthcare across the spectrum, from OBGYN, pediatrics to surgery, emergency medicine, internal medicine. And I think it's important because people who are speaking look like you also. And so when you're young, say in college or medical school, when you get exposed to that, you realize that this is a possibility, and it helps to grow the pipeline.
Is there, thank you, Dr. Curry. Anyone else who wants to comment on the NMA and its significance?
So I'll speak to it just real briefly. The NMA was formed, the National Medical Association was formed in 1895. It was formed because in 1870, the AMA made a formalized policy of exclusion of people of color and women. In 1895, Black physicians came together because there were Black medical schools that were in place that were putting out Black medical graduates. In fact, in 1920s, there were more Black physicians per 100,000 population than there are today. Many of them were NMA members because they had no other avenue in which to convene themselves as an educated cohort of people. And so the NMA was one of the key drivers for Medicaid and Medicare, which the AMA was vehemently against. The NMA continues its fight today as we were champions. As when I was in the Speaker of the House of Delegates, I was one of the champions that helped to get the Affordable Care Act passed. And we were one of those that advocated that with a tri-caucus with the AMA and the Asia Pacific Islanders as part of that caucus. And excuse me, not the AMA, but with the National Hispanic Medical Association. So the NMA remains a viable opportunity for young physicians to grow and learn about their craft, about the history of medicine as it relates to us as Black physicians, and to dream a new dream about what we can do for the future to make this our shoulders prepared to stand on as we stand on the shoulders of giants such as your father, Dr. Johnson, who was a mentor for me and very influential in me becoming the president of the NMA.
Thank you, Dr. Bright. Dr. Quinn Beasley, you're muted again.
I just was adding to Cedric's great comments about your father, that he also was a president of the NMA as well. And I think for me, he exemplified all that is great about NMA, and that is a group of leaders who understand the plight of African Americans and Brown people in terms of their health needs and health inequities, and going beyond, as Dr. Bright articulated, and working outside of their offices in communities, in the ballot box, in the legislature, to really try to work at all elements of the social determinants of health. And again, these are things that are in people's environments. They are, racism. They are SES, which actually is socioeconomic status. They work on trying to create equity in all of those domains. And I think the other piece that not only your father exemplified, but also Dr. Bright as president of NMA and just in his personal life, and actually I could say everybody on this call, won't back down, right? And will continue to fight even when it is difficult. And so we talked about the massacre in Wilmington. Well, just know that many people who are engaged in this have to be prepared for people trying to stop you in these endeavors, because the system was designed and is working exactly as it was intended. And so the NMA as a group collectively works together. And as we all know, there are strength in numbers to actually combat those things that allow inequities and health disparities to exist as a collective body that is intelligent and wise, not only in policy, but in science, but also in clinical care and community outreach.
And I think one of the strengths of the National Medical Association for us in this country is the oldest and largest organization of Black physicians in the United States. And so as we navigate many changes in our culture, and we try to navigate anti-racism, that organization is still one that is very much relevant today, and we've seen the relevance over and over and over. So for me, as an OBGYN growing up in Durham, North Carolina, one of the people, as was mentioned, Dr. Charles Johnson, as the president of the NMA, when I was growing up, was something that was a very big deal for me as a child, to know that there was somebody who was in charge of such a large organization who was from Durham, North Carolina. And as I grew up and attended these meetings, I realized just how many people from Black folks, brown folks, from so many different subspecialties of medicine were represented and talking about issues in a way that really grounded them in my experience and in my needs as a young Black woman.
And we should also attribute to Dr. Maria Small that actually she is chaired the subcommittee or the section on OBGYN for
And just
NMA.
included my chair position in that organization. And we did a program at Morehouse School of Medicine, a pathway program with high school and college students, and also a program for residents in obstetrics and gynecology to try to improve and support them from different places all around the country as they try to navigate OBGYN. So I think that those kinds of programs happen in multiple sections in the NMA. And that's the kind of work that is so important and still very much a part of that organization.
Thank you so much for the flowers for Dad. He would be humbled and very proud of all of you all, as you well know. What is the health of the NMA? How is it? How are you all doing? Are young physicians, African American physicians, coming into the NMA?
Well, I'm excited because I know that everyone on this one, even Jensen, Dr. Hall, has been to an NMA meeting, and his wife. And so, and many of these folks on here, well, Tamara and I are more constituents with Maria, but I know that Charles and Jensen were both great people that I helped to train at some point in time in their lives. And so I'm beginning to see more and more people who I have worked with either as medical students or trained who are coming to the NMA. And the truth of the matter is that the NMA now belongs to them. You know, my age, I've been a president, now I'm a past president. And my goal is to make sure that I continue to pull those young people in because it's now their organization. It's now their time to shine. It's their time to lead. And they're coming. Oh, yes, they are coming.
And I think, the other piece, and I would agree with Cedric 100%, and it's exciting to see. And I think, as Maria described, those are really pipeline programs that her section has, and I would bet that every section has that. I think the other thing that was important for me in participating in NMA, and then also knowing your father as a leader and being at the installation of your dad, as well as Dr. Cedric Bright, gives you the opportunity and the courage and the role modeling to take on these roles in other places. And so your dad was really pretty instrumental in, walking me through and advising me as I actually became the president of a predominantly white organization. And so I think that that's important as well. Like NMA trains you to be a leader, and the leaders from NMA give you the role modeling to become leaders in multiple places. Because the reality is we're needed in multiple places and spaces. And so during my presidency of the Society for Adolescent Health and Medicine, equity became part of the mission and the vision when it hadn't before. We developed strategic planning related to that. We developed a racism toolkit to be used in practices where adolescents are. We developed policy statements. And so the organization looks very different than it looked before. And we developed a strategic plan to actually get other leaders within the organization who are Black and brown by we all know that there's a pathway to doing this, and sharing the knowledge of that pathway and what you need to do to be prepared and be able to lead an organization is important. And I know that your dad shared that same pathway with Dr. Bright so that he knew what he needed to do to get to be the president of NMA.
Is there intentional mentoring, since you mentioned that, within the NMA?
Absolutely.
Excellent. I want to segue into looking at where we are. What is the state of the diversity of the healthcare workforce? And what efforts are underway to increase the representation of BIPOC in medicine? Don't everybody speak at once.
Well, in the world of cardiology, Blacks make the same 3% of the total amount of cardiologists in the U.S. they did in 1970. And so aside from the NMA, we have the Association of Black Cardiologists, which has been modeled after NMA as far as some of their pipeline programs, scholarships. Out of the Association of Black Cardiologists, we have the first Black female president of American Heart Association, Dr. Michelle Albert, who just became the president at the last meeting from AHA. Looking around, I see the same percentages of whether it's infectious disease, other medical subspecialties, surgery. It seems like the numbers are higher, but the percentages are not. There are pipeline programs and diversity and inclusion work being done in the American College of Cardiology. It seems to be somewhat slow going, but there is some traction being gained, but it's a slow process.
Thank you, Dr. Curry. I'm wondering where we are in terms of percentages, like the percentage. I mean, how often do you see yourselves when you're walking through the hospital? I mean, what is that, what is the makeup of the medical staff, medical faculty where you are, and so forth? Dr. Bright?
So when we look at the national numbers, African Americans typically make up about 6% of physicians in America. Typically, we represent about 5% of physicians in America, and we make up about 6 to 7% of medical students in America. And yet, that's been a significant gain over the last couple of years because we've seen a significant number of Black males who have come into medical school over the last years. In 2014, there were 514 Black males who came into medical school. That was less than the number that came in 1978. But by 2022, we had 863 Black males who came into medical school, with significant increase showing that if we had intentional efforts to increase that pipeline, we can make it happen. And so
that's what the difference is. I mean, what between 2014 and 2022? What is the
intentional programs the AAMC put out a monograph that was called "Altering the Course: The Dearth of Black Men in Medicine," and that became the clarion call that led to schools starting to look more and more for Black males along the pathway. And to start being intentional about bringing them in. And I think that's a part of it. The other aspect of it was the changes in the admissions policies. Being an admissions officer, we've used more bias training, bias training to help mitigate bias in the admissions process. And that has also helped to increase the number of Black males and Black females coming into medical school.
Right. So I would imagine then it also helped that they had a Cedric Bright sitting in the position that he's sitting in, right?
Well, it doesn't hurt to have Black deans, and we certainly now have a large cohort of Black deans across America at many top schools. From Penn State to Stanford to University of Chicago, Illinois to Harvard, not at Harvard, but Yale and other places like that, where we have now Black deans, and that does make a difference. And so that's important as well.
Dr. Hall, if a young person was coming to you today and they were interested in some aspect of healthcare, what direction would you point them in?
That's a good question. I guess I'm biased by my own experience. I would say to consider nephrology. There's a significant need for not only really good, motivated, passionate clinicians with an understanding of the African American community, but there is really a desperate need for research in kidney disease. And so I would encourage them not only to consider nephrology as a clinical discipline, but also to consider the possibility of contributing in the research space, and particularly the basic science research space. The reason why I would say that is because there have been some significant advances in basic science, our understanding of the genetic predisposition that African Americans have to the development of chronic kidney disease and end-stage kidney disease. An investigator here at Duke has taken on a project testing a therapy for a common genetic mutation that occurs in African Americans, particularly people of recent African ancestry, which would be kind of another way of saying those that were have ancestors that were kind of trafficked in the transatlantic slave trade. This particular mutation, or these mutations, have actually been shown not only to be expressed almost exclusively in African Americans, but to cause damage and injury to the kidney filter on a particular type of kidney disease that up to this point tends to be unresponsive to therapy. He is actually not only testing human samples to better understand the biology of this particular mutation, but testing a therapy that he's determined might be helpful. And I think that particular focus, that sensitivity to the experience of African Americans, that understanding of the culture and how we sort of exist in this country, has made it position him to be just uniquely receptive to the need for answering questions around kidney health in African Americans. So I would tell anyone who's considering a career in medicine to put nephrology on the top of the list. It's one of the places where I think you can have a lot of impact really quickly, and actually make a difference for people in your local community. I always raise the example: if you ever go into a dialysis unit, it looks exactly like a barbershop, a bunch of chairs with Black people in them. And that's the type of thing that I'm looking to change. And so I'd make the endorsement to come change that with me.
Thank you. That's very insightful. Anyone else? Dr. Small, I see you smiling back there.
Obviously, I'm going to say come into obstetrics and gynecology, but there's a wealth of different things that can be done in that specialty, and a great need. And right now of specialties, it is probably a little bit more represented by Blacks. I think maybe 11% Black is our percentage, maybe a little bit lower in more recent numbers, but the field is wide open as well in terms of ability to do surgery, to do research, to do clinical medicine, to do advocacy. We just need help. I'll pass.
So I would say we need you wherever your heart desires. It could be any specialty, just please come on. But I do want to make people, since we're talking about our own specialties, aware of other opportunities. And so my route to medicine started out in med peds. And I did that because, as I told you about my family, I wanted to be able to take care of everyone, because everyone around me will seem to be sick and not getting adequate health care. And so the great thing about doing med peds, and I believe Dr. Curry is med peds as well, is it gives you the opportunity to do a variety of things once you're done. And so compared to family medicine, you have the opportunity for greater subspecialization, either on the pediatric side or the medicine side. And I wanted to have the opportunity to do both. I started out doing primary care, and I never envisioned myself being a researcher. I never considered myself being an academician. And again, it's about exposure. It wasn't until I was moonlighting as a resident with some of my white colleagues who were actually in a Robert Wood Johnson Clinical Scholars Program. And they actually encouraged me to actually do that. And that's where my career in academic medicine was born. And then I used that career in med peds to actually do adolescent medicine, which actually is a nice way to kind of branch those two things. So like it gives you some medicine and it gives you some pediatrics. And when I think about kind of the fields and kind of how they are represented, pediatrics is actually one of those disciplines where you actually have a greater proportion of women physicians than men.
What is med peds, Dr. Cohen Beasley? How about med peds? What is?
Yeah, so as I explained, it actually is the ability to be board certified in two specialties at the same time. So you can do pediatrics as a separate discipline, and you can also do internal medicine as a separate discipline. When you do med peds, you actually, when you finish your residency, which is a period of 4 years, are board eligible in both internal medicine and pediatrics. So what that means is you get training in taking care of children and adolescents through pediatrics, and then also taking care of adults. What MedPeds gives you the ability to do that family medicine does not is it gives you greater experience, say, in intensive care or very acute situations. So like I've been in the MICU, the PICU, the medical intensive care unit, the pediatric intensive care unit, and all the intensive care units except for the surgical intensive care unit. What you don't get that family medicine gets is that obstetrics that you would get. But the difference that you can get from internal medicine and pediatrics combined is, one, it's 4 years instead of 6 years if you did those things separately. But it also gives you the opportunity to subspecialize in pretty much anything that you want except for obstetrics and gynecology, which is its own specialty. But you could actually be the nephrologist that we've been encouraged to be on this call as well. So MedPeds gives you a lot of flexibility with your training and the number of individuals that you can impact, particularly from a primary care perspective, if you don't subspecialize.
So what she just told you was that, that's the discipline of people that just are so smart, they can't figure out which one they want to do. And so what I'm going to say is internal medicine. And I got into academic medicine serendipitously by writing a paper about perceived barriers and bias in medical education by race and by gender. And that has changed my life because I never thought about academic medicine. The only thing I ever thought about was kind of becoming a doctor and going back and serving in my community. And so over the last 30 years of being in academic medicine, I've had an opportunity to be the gatekeeper, to be that conduit to help children that come in saying, I want to be a doctor, but nobody in my family's a doctor, and I don't know how I get there. And I've been able to help to navigate that path with them with some success by God's grace. And the second thing that I would say about this, why it's so important, we talk about changing the face of medicine. Dr. Cohen Beasley talked about that we need to have more physicians of color to help take care of people of color because the outcomes are better. Compliance is better. Physician burnout is even better, right? When you have race congruence. Well, in order to do that, we have to have more people who come into academic medicine. And so we often try to change the face of medicine by increasing the number of students. To me, that's the tail wagging the dog. What we need to do is develop more physicians who go into academic medicine such that they can be there to treat these, to help our majority counterparts understand how they're mistreating people of color, and such that they can get more culturally humble and develop a culture of humility that allows them to be able to take care of people of color with a much greater sensitivity and empathy. And they also will help them to understand, become more suspicious of the structures of racism within the health system. So we need more people of color like myself and like all of us here in academic medicine, because that's how we will change the face of medicine. And then that's how we will start the reaching of health equity as opposed to health disparities.
Mm-hmm.
And I just did internal medicine. I didn't do the pediatrics because sick children depressed me. But I was glad a lot of my classmates went into pediatrics. And in cardiology, I never thought I would be a program director. I'm a fellowship program director, which if you had asked me 20 years ago, I would not have thought about that pathway. But I get to mentor students, college students, residents, and anything they want to go into, but it's something that it's a different challenge that I didn't expect. And so I love the internal medicine side. I thought about nephrology also because I liked it a lot, and critical care. But I got pulled towards cardiology, and it just seeing people who look like me with all the cardiovascular disease, it felt like it grabbed me.
So you all made me think of another thing that was important. It's interesting that none of us originally well, at least Cedric and I should say, Dr. Bright and I didn't necessarily intend to be in academic medicine. My story is exactly the same. I thought I was going to go back and work at a community health center because that's the kind of care that I received. So that was what was modeled for me. But I also want to make sure that we, as part of academic medicine, actually become researchers. So my entree, the fellowships that I did were primarily research fellowships, and that allowed me to kind of be able to advance and have tenure and, you know, be in positions where I could make sure that we could address those issues of inequity. And that did not come without any risk. Every single person on this call has experienced some risks as they've challenged the system. The reason why being engaged in research is important is because it helps you to determine, it's almost like writing history. What questions actually get asked? Who asks the questions? Who do you ask the questions to? Are you asking questions that the community feels that is important? And are you allowing the community to help you interpret those questions? So I'm a community-based participatory researcher. And how do you actually ask the questions and challenge the research and do research to challenge the misconceptions and actually racism within medicine? And so in the same way that we were talking about the disciplines that we all could, you know, have, we would recommend, I would also recommend that we need more researchers. We need more people of color to be engaged in the science, to write the science and write the history that actually tells the true pictures, because you can't find an answer that you're not looking for. And we ask different questions. We get our community involved. We work with them and we learn from them. Even if we're a part of that community, our experiences are different. And so I just want to put a plug in there for research, because it, again, is a really important part of history. People have been using old research protocols or old research findings for years and never testing them, and they were injurious to people of color. So we need to make sure that as researchers, we can rewrite the history in a way in which it's true and a way in which it benefits people of color, because we've asked the right questions and engaged the right people.
Dr. Hall, thank you for, I was going to come to you. Thank you.
Yeah, I was just going to say one addition that I would make, and it seems like a theme that's developing from everyone's answer to the last question, is some encounter, something of significance that resonated in each of us around sort of a mission to give back to our communities. One of the ways that we give back, and this is, again, a credit to your father, Dr. Johnson, and also to Dr. Bright, who specifically mentored and taught me medicine at the Durham VA on many a Wednesday afternoon, is the idea of representation and having mentors in place. I serve as the Vice Chief for Diversity, Equity, and Inclusion in the Division of Nephrology. And one of the main difficulties that I think I have to address is helping people connect with mentors, and more importantly, sponsors in this environment that will invest in them, sort of help them to understand the critical features of professional development, and sort of stand in the way, almost as a heat shield for a lot of the opposition that they will face as they make progress towards their professional goal. Each of us, without knowing everyone's specific, life circumstance, I'm certain that every one of us has had at least one mentor who has been impactful and tremendously important in the way that we've shaped our careers or are thinking about what we want to do professionally. So as you're considering careers like this, one of the things to do early is to find a mentor. They don't have to exactly do what you want to do, but they've traveled a path similar in ways to what you might want to do, and you need to connect with them. Sometimes it's difficult for African American young men in particular to raise their voice and ask for that type of help. There's often, as I encounter it, a little bit of a hesitance to engage with people that way, but people don't know what you need unless you ask them. So it's not going to be a harm to send someone an email or to walk up to someone. Hey, I noticed that you're doing this. I think I might want to do that too. Would you be willing to mentor me? Help me to understand how the process of becoming like what you've become, or something like what I might want to be. It really is incumbent on us, especially at the early stages, to raise our voices and to speak to people who could be of influence. And I just want to make that particular point, because I recognize that as we're going along in these discussions, people are almost they're almost mentioning mentoring, but without saying the word. So I just wanted to say the word, and I'm grateful to all the mentors that I've had, Dr. Bright included, who have really shaped me and helped my vision clarify itself, declare itself over time. There's just that type of insight, how you look from outside of yourself. That type of input is invaluable, and it will serve you your whole life long. So you should definitely seek good mentoring and find it where you can, and do your best to maintain it.
One quick question to follow up, Dr. Hall, for the benefit of our young people, the difference between a mentor and a sponsor.
Yes. So in practically speaking, in my professional life, mentors have always been those people who show me how to do a thing, who will take you under their wing, and they'll either show you how to do research or some sort of clinical activity. As I mentioned, when I was in the internal medicine phase of my training, part of that I did at the VA. And there would be the afternoons where I would spend some time down in the first floor clinic, and you had a number of different people there that would teach you different aspects of medicine. I always loved the days when Dr. Bright was around, and he was sort of my direct mentor, because he just spent the most time. So it wasn't like you were just dispatched to different areas and then, kind of come back, report, and go again. You actually got a little time to talk about the cases, to sort of puzzle over them. And I found it really enriching. So that was sort of a mentor experience. And then in other ways, discussions outside of clinic that I've had with Dr. Bright, for instance, have been similarly enriching. A sponsor, however, is someone's a little bit different. They tend to be almost the person that will kind of put their hand on you and say, this one's with me. This one is going to make it through. So when you run into those little issues in a professional environment where your own muscle is not getting you through, the sponsor will be there to say to the people who have gateway access that, look, this is the one I want to go through. And all of a sudden, you'll notice that things get a little bit easier for you. Sponsors are almost making an investment in who they think you're going to be, and they're willing to put that nickel down in time, right? So it's a different type of relationship. Certainly, your mentor could be your sponsor, but it doesn't always have to be that way. What I find for African Americans is that, particularly in majority institutions, mentors are essential, but sponsors make all the difference. It's the difference between being an assistant professor for, 8 years or advancing up the ranks.
Right.
And it's a good sponsor will make that happen for you. And so it's the only thing that I can think of that is probably the hardest to get, but the most valuable to have.
Can I add something to that? And so I agree with everything that was been said, and I just want to put a little bit more fine tuning on it. So generally, your sponsor is going to be someone who's in a position of power or in a position that you want to attain. And the only way you get to that particular position is that you have gone through the system. And so giving you very specific kind of examples. And so I also want to make sure that we understand that because of that privilege and access that sponsors have, some of my most initial important sponsors, of course, other than Dr. Johnson, who was a very proud, intelligent Black man, was that many of my sponsors initially were white people. Why? Because I was the first Black med peds resident at at Duke and the first Black pediatric tenured faculty at UNC. And so there weren't people within my system to actually have those opportunities to give me the way to do that. So just to give you a practical example, one of the societies that I serve on the board of directors for, it's called the American Pediatric Society. It is the highest honorific society that we have, and it's also a research-based society. The only way you can get into this society is somebody who is a member has to nominate you. Well, guess what? One of the things we're trying to do now is to increase our African-American people who are in that organization, because in fact, we know that we're more likely to nominate our colleagues. And so really the sponsor has a special access and privilege, usually that comes from their longevity in the field, where they can give you access because it has to come through them. And so that can be promotion committees. It could be, I've been able to serve on the U.S. Advisory Committee on Immunization Practices. I had to be nominated for that. And then many of our honorific societies. So that sponsor has a unique access. And for some, as he was mentioned, they can also be your mentor. And so the other piece I want people to think about is that I have many mentors and many sponsors, and now I serve as a mentor, a sponsor, and a coach. And you have multiple mentors for many different reasons. It might be achieving work-life balance. For me, I have women mentors because that is a unique experience. And so make sure that you don't exclude the potential assistance that you can have from a person who doesn't look like you, and the influence that you as a mentee can have on your mentor. I've had a lot of discussions with some mentors who have been white and been able to enlighten them and change kind of the way they practiced and the way they look at things. And so mentors and sponsors are really important, particularly if you're trying to advance in most of our systems.
All right. I want to be considerate of your time, and I can see that we've gone over our time here. I've really enjoyed this. I have one little question that I'm going to ask that you all answer succinctly, and you can't say my father, but I want to thank you even before I do, and on behalf of Dr. Cyrus, Sylvia Cyrus, who's our executive director, for being here. This has been wonderful. But I have one question for you, and that is, if there was one person that you wanted to honor, as we have been talking about sponsors and mentors and that kind of thing, who would that be and why? And we'll close with that.
Well, I'm sorry. It was your father. I had a 34-year relationship with your dad, who mentored me from the beginning of my career at UNC, and then, Duke. We started at Duke, but progressed through UNC and continued when I moved to Alabama, which was actually his home state, where I never, ever thought I would be. And I think we talked a little bit about that mentorship that's really special when it actually occurs outside of the four walls or the halls of the institution. And so we had a relationship that really was like family, that gave me the opportunity to meet his family and be a part of even, family celebrations. And so that was critical. But I want to also talk about another really important relationship. And I know I apologize for the other two speakers who are here today, but relationships like I have with Dr. Bright and Dr. Small, we all went to college together. We've maintained those relationships. Dr. Small's family is my family for other reasons. Her sister is one of my best friends. And those kind of relationships are important. And so when we think about that sponsorship, when we think about mentorship, I also want us to remember and think about like peer mentorship, your support system, that when things are tough, it's nothing for Dr. Bright or I to pick up the phone and get advice from each other or be there to support each other. And the same thing with Dr. Small. So whatever level of training you're at, make sure you find people also who are going through with you, who you can trust and talk to and just bounce ideas off. I often have to say, am I taking this the wrong way? What do you think about what I've just experienced? And so I'm grateful to your dad. I'm grateful to my friends, Dr. Bright and Dr. Small. And I would encourage all of us to develop those kind of relationships. So like laterally, as well as people in a horizontal way, such as your mentors and your sponsors. But I'm sorry, your dad.
Oh, yeah. Thank you for that again. And I mean that. So real quick, before the others, everyone else goes, how did you choose your sponsor?
So, I'm sorry, I'm going to let another one of my colleagues talk.
No, you can go ahead while they're caught.
I'm going to tell you something too about that.
Yeah.
This, Maria.
How did I choose my sponsor? It was, I'm sorry, Maria. You can come, I'll finish real quick. I don't know so much that I chose my sponsor as much as I proved to that person that I was worthy of them sponsoring me. And what that meant was I had to work like a dog to meet their standard. And then once I met their standard, then they were like, okay, now I can sponsor you, because they're not going to sponsor somebody who's not meeting their standard.
And sometimes you don't know who your sponsors are. And I think that's often the real scenario where someone is behind the scenes, often in positions of power, and they're able to advocate for you. And you may find out later that they were in the room advocating for you. And I think that's often the case in many situations. And I think we mentioned this whole promotions and tenure process. You don't necessarily know in many institutions who is writing letters to support your application for promotion or for tenure. And then you find out later that some of those individuals were, in fact, your sponsors because they wrote a very important and pivotal, insightful letter about your qualifications to be tenured in that institution. Mm-hmm. So I think sometimes sponsors may not be as directly known to you, but they may come to you may come to know who they are later because they're aware of your accomplishments. Mm-hmm. But we have to be in the room. We've got to be in the room. So as one gets there, you have to help bring others.
Thank you. And thank you to Dr. Bright for what you shared there. I think that was really, really important. For the young people that'll be watching this, to hear that it's not always you choosing. It's based upon how you perform each and every day, right? Consistently, that people are looking at and they take notice of. All right, so we'll continue to go around. Whoever wants to go next.
Well, I can think of one person that had the greatest impact. Her name was Michelle Nguyen. She was a nephrologist here at Duke University, world-class geneticist, and just an outstanding human being. And unfortunately, she passed away from pancreatic cancer. I credit her with turning my eyes away from cardiology and and towards nephrology. So we actually went in opposite directions, but just the most engaging personality really kind of confronted me with the suffering that was going on right in front of me. I had no idea about how difficult the patient experience with kidney disease was before I spent time with her. And so I would love to honor her in any way possible. And I'll keep trying to do that until I stop breathing, because I do honestly believe that she's the reason why I'm here.
So I'll go next, and I'm just going to say, besides what Tamara said, which I agree with everything that she said, because she's been an extremely valuable person to me since she was a freshman in college. But what I would say is the ancestors, all of the ancestors who had a dream, who in slavery thought of a day when their children would have an opportunity to be somebody, to become somebody, and the dreams that they had, and the sacrifices that they made, that allowed me to go to the places that I have gone, is not lost on me. And I'm also always reminded that to whom much is given, much is required.
And I'll add first, Michelle Nguyen, I remember from residency, she was phenomenal and awesome. She didn't turn me into a nephrologist, but she tried. But I will say, in my family, it's not my father, I would think, but my aunt, who's a gastroenterologist, Sadie Curry, she was the first Black female gastroenterology fellow at Duke in the 70s. But what the difference that she made for me was my father was very, very serious, and he trained with Dr. Johnson, and they were very serious, deep conversations. And medicine seemed very, very serious, which it is, but my aunt made it seem fun and engaging. He said there's a lot that you're doing that's just enjoyable, and you get into it and you realize when you like it and you love what you're doing, it's a interesting and fun profession, and it's full of surprises. So she brought some of the fun and interest into the profession, aside from the serious work that we have to do.
Dr. Small? Unmute, please.
I thought I answered, but maybe I didn't. I have to pay homage to what Dr. Bright said, about the ancestors and the strength of colleagues. But in terms of the ancestors, somebody who is very prevalent in my head right now, because he recently departed, is my father. And he was in public health on the other side, not the other side, but in another area of medicine, and really not only just taught me how to look at health in a community sense, but also how to be part of and enjoy being part of community that you live in through different just community engagement, just being part of your community, loving your community, and then really cherishing that as your focus. And so I think for me, as the person I'm thinking of right now in terms of my ancestry, because is my dad, but I think honoring our ancestors by continuing to persevere and continuing to not disrespect their sacrifice by not voting and not doing the best for ourselves is something that we have to continually remind ourselves of with history and with our lives.
Maria, you're not lying. Your father touched so many of our lives.
Another subject. We're going to do public health in the next discussion.
There we go. Next time.
Look here, thank you all again for being here. This has been fantastic. We're going to draw the State of Black Health and Future of Medical Trends roundtable to a close. But this has been wonderful. So thanks again for being here.
Thank you.
Thank you.
Mhm.